If you guys say something in the comments, I may not see it. I'll try and catch up with those every once in a while. All right, so we're going to start off talking about some advanced EKG interpretation stuff today. And we kind of touched on this a little bit the other day because there's a lot of stuff we've historically missed by only looking at one lead. So, and you don't necessarily have to have a 12 lead for this. You can use V1 and kind of move it around. But even with just a traditional 3 lead or 5 lead, there's a lot of information we miss out on by just looking at one lead. So historically, the only reason we changed leads was we couldn't see, or maybe the lead fell off or something like that. So what you're going to find out is if you move through more and more leads, that you get a lot more information from the device itself. So part of it's knowing how to work things, part of it's knowing what you're looking for. We're going to start off by talking about some electrolyte abnormalities that you will probably see again. They seem to really like these for boards, and you'll probably see them on your patients as well. One of the most common ones we run into is hyperkalemia. So the classic hyperkalemia is flat P waves. They tend to have a very low amplitude because of the slowing of the conduction. The QRS complex tends to be very wide, and as it gets wider and wider, you'll notice that it kind of fuses the QRS and the T, so you can't even really make out a ST segment in there. And then the classic pattern is a tall, broad T wave. But what you'll see sometimes when patients become profoundly hyperkalemic is like this image over here on the right. If you look at lead 2 there, notice how it looks like kind of a big, broad V-tach, or what we'll call a sine wave sometimes. So as patients become profoundly hyperkalemic, you may not even have a discernible EKG complex. It may just be that sine wave. Not a good thing for your patients, obviously. But what you'll notice when that happens is that they tend to respond very poorly to things because they're kind of desensitized to lots of different things as far as medications and conduction. Hypokalemia, on the other hand, is a little harder to discern, but it's kind of recognized by ST depression and flattening of the T wave, and you may actually have negative T waves. But the U wave, which is really hard to see, is really kind of the hallmark of hypokalemia. And the U wave is that, if you look at that picture up in the top right corner, is almost like an extra P wave on your EKG, except as you start marching things out, you may notice that it tends to stand out. It's not quite as consistent as other things you'll see. Sorry, I'm a little snotty today. And it's almost always going to be facing the same direction as your T wave. So if you're looking for like polarity, it's generally going to be the same direction. And you can almost always see it better in V2 and V3. So if you're looking for it, that's probably the easiest way to find it. We don't entirely understand where U waves come from. We think it may be like a delayed repolarization of the Purkinje fibers, but we're not sure. But if somebody mentions a U wave, it tends to be pathognomonic for hypokalemia. Hypercalcemia, on the other hand, tends to be kind of a broad-based, tall peak T wave. And then a lot of times as it becomes more and more profound, you'll see that the QRS becomes extremely wide. You lose the R wave, you lose the P wave, and you tend to have kind of tall peak T waves in there. It's a little bit harder to discern than hyperkalemia, but in severe states, you may see that it's very similar to that, where you have kind of that wide QRS, almost like a sine wave, but not quite as pronounced. Differentiating the two of them from an EKG is hard to do. Just know that hyperkalemia tends to be more common than hypercalcemia. Hypocalcemia, on the other hand, tends to have very narrow QRS complexes. You'll see that your PR interval gets very short. Your T wave will flatten and invert. So you'll have like a depressed T wave, not a depressed ST segment. You'll see your QT interval becomes very long as it's repolarizing. U wave is also common here, and you may have prolongation of the ST segment and the ST depression as well as it gets worse and worse and worse. Is you'll notice there's a lot of EKG overlap between like hypocalcemia and hypokalemia. So sometimes the lab value is really the only way you can discern the two. But just know if you start to see U waves, you probably either have low calcium or low potassium. And a lot of times the clinical picture of the patient will help you kind of figure out what's going on. The J wave is commonly seen in, or excuse me, the Osborne J wave is kind of commonly seen with hypothermia. So if you see a question about hypothermia, a lot of times you can just home in on that they're probably talking about a J wave. You may also see it with hypercalcemia, but it's generally going to be more common with hypothermia. And what a J wave is, if you look over here at these kind of bottom complexes, as you're coming out of your S, you'll notice that, out of your R wave, you'll notice that you kind of have this notched S as you go through that J wave, and then you go into your ST segment. Sometimes it's hard to distinguish that from ST elevation. Just know that when you come out of ST elevation, a lot of times from that R wave, you won't have that notch. It will just kind of come straight out there. If that makes sense to everybody. Best to see it oftenly in V1 and AVR. Delta wave is kind of an upstroke in your QRS complex. Usually, if you see this, it's going to correlate with something like Wolff-Parkinson-White syndrome. So best place to look for it is going to be like in V1, V2. And all you're going to see there is kind of this upsloping as you're going into your QRS complex. So instead of kind of being a crisp upright image, you'll see that it just kind of gradually transitions into it. In minor cases, it's very difficult to see. In pronounced cases, like the one in the first rhythm strip there, it's pretty pronounced and pretty easy to see. Whereas like the second one and the third one is a little bit harder to make out. Other things you'll see in there, very short PR interval, and then kind of a big QRS. Any questions about those before we kind of transition into the main things we're going to run into as far as EKG stuff? All right, so talking about stuff with 12 lead EKGs, there's a couple big things we run into. And as we go through this, we're going to talk about monitoring placement, the actual correct placement of the leads, because if we don't have our leads in the right position, it can kind of augment our view, which can make it a little bit more difficult to interpret things appropriately. And then we're really going to focus on axis and hemiblock determination, bundle branches, talk a little bit about differentiating VTAC from some of the other rhythms using our axis, and then touch on acute MIs. Sorry if you hear my kids in the background. So things to think about with a 12 lead that it really comes through kind of clutch for us. Who's at risk for complete heart block? You'll realize some common medications we give may be dangerous to some of these patients, and identifying our axis in our 12 lead may be pretty helpful. We'll also talk a little bit about how you can do axis determination without a 12 lead. Using that to figure out which patients are at high risk for hemodynamic compromise. And then we're also going to kind of talk about complications of an MI based off of the 12 lead we're looking at, and then just look at a couple of different case presentations. So this is the traditional placement for your 5 leads. Now, I say traditional placement because, especially in anesthesia, we wind up augmenting this a lot of times. But one of the things you have to consider in this is that as you start augmenting things, you may lose a lot of your perspective. So traditionally, think about the focus point to your heart, and especially as you start talking about axis determination, that's really important for you. But RA, right arm, left arm, uh, chest or cardiac lead, or right leg and left leg. So lead one looks at our heart going from the right shoulder to the left shoulder. So think about your positive impulse, or like your viewing impulse, as being the left shoulder. So a lot of times what you'll see is as that follows the normal cardiac pathway, that your EKG is going to be upright. Lead two is kind of the traditional one we follow. So you're going from the right shoulder down to the left leg. So again, this is going to be positive. A lot of times we use this for monitoring, really because it's very easy to discern kind of the normal cardiac conduction system from this perspective. So that's one of the biggest reasons that we use lead two for monitoring. Lead three goes from our left shoulder to our left leg. Again, it's following the traditional cardiac conduction system. So a lot of times we use this for monitoring. But one of the things I want you to think about when you start looking at these is what part of the heart gets the best perspective here. So if I'm concerned about some sort of atrial issue, it may be beneficial for me to go back to lead one because that's really giving me the best or the closest view of the atria. Whereas lead two tends to follow kind of both views of the heart, so it's going through the traditional conduction system. And then lead three gives me a little bit closer view of the ventricles. So if I'm concerned about some sort of issue in my ventricles, that may provide me a little bit better view. Now we're going to talk a little bit about why we have to have all these other leads because a lot of times, like I said, a lot we'll just rely on lead two for things. Um, One of the big things we really have to worry about is what's a medication we give to almost all of our patients very routinely. It's part of that normal induction sequence we give everybody lidocaine, right? Lidocaine can be beneficial because it's a potent local anesthetic, but it's also a pretty potent antiarrhythmic. So that's why we have to be really cautious for giving it to some of these patients. And if we just focus on looking at one lead, we may miss out on potentially a bifascicular block. When we start getting down and looking at the bundle branches, you'll really understand why it's a little bit more important for us to make sure we're paying attention to that in all our patients, especially those that we're concerned about cardiovascular instability. So this is one of the big things. For a long time, we were kind of taught to look at things in more than one lead every time. So for instance, in ACLS, a lot of times if we thought something was asystole, as a safety mechanism, they would have us go ahead and confirm it in a second lead because it may be a lead that's fallen off or it may just be providing us kind of a very poor perspective for that patient. So things you have to think about, am I truly seeing the best image for that patient? And if not, if I'm going to make a pretty significant clinical decision, let me go ahead and take a look at another lead. So if you had a patient that you thought might be having an acute MI, what leads can we see, or which part of the heart can we see with a 3 lead or a 5 lead EKG that would tell us that they were having an acute MI? Anybody know? So think about your leads. So lead one reflects what? The high lateral portion of the heart, right? What about lead two and lead three? The inferior wall of the heart, right? Yeah. So lead two and lead three are the inferior wall, and we'll look at kind of some easy ways to remember the 12 lead stuff here in just a minute. But two and three are the inferior wall of the heart. Remember the other day we talked briefly about acute MIs, and I said that if you wanted to diagnose somebody with an acute MI, you needed to be able to see ST changes in two contiguous leads, right? So I can see lead one and know that I've got potential damage to the high lateral portion of the heart, but I can't see AVL on a 3 lead or a 5 lead. On the other hand, I can see lead two and lead three, which both look at the inferior portion of the heart. And even though they don't provide me the same diagnostic quality as a 12 lead EKG, I may be able to recognize from that that they have ST changes consistent with damage to the inferior wall. So the reason I say that is we may get glimpses at it from other leads, but we need to make sure we're taking a big look at all the other leads before we make any sort of clinical decisions. Not necessarily just with acute MIs, but patients in general. So when you think about lead placement, there's a couple different things that come into play. If you've ever done a 12 lead on somebody, you know that if we put things on moving parts of the body, they're very difficult. So a lot of times our patients are in distress, they're breathing. That can be problematic for us because instead of getting a nice tracing, you may see that you've got a whole lot of artifact from them breathing. Other things that can be problematic, if you have somebody that has large breast or a lot of chest hair, you may have to take action to kind of correct that. You can shave hair. Obviously, we're not shaving off any breast, but you may have to kind of move your lead a little bit so you can get it to stay in place. Because if you have a large breast, it may not be the same position that it should be in relation to the heart. Same thing with hair. Go ahead and shave it off. A lot of the electrodes now do better than they used to. but you may still have problems. So just think about where your lead is going in relation to the patient's actual anatomy. Other things that can be helpful for you. A lot of us do chest x-ray, or excuse me, EKGs with our patients sitting up because that's most comfortable for them. But we generally recommend that you actually have them laid flat, um, because it gives you better anatomical location. The leads don't have tension on them because if they're sitting upright, gravity is obviously working against us. But if they can't tolerate it, you can certainly do it with them sitting up. If need be, wipe the chest off if they're diaphoretic. Consider using something like alcohol. Just take an alcohol prep, wipe it across the skin. As it evaporates, it'll dry. A lot of times that will help the lead stick better. Other things you may have to consider for patients, we're really considering like really healthy patients for this, not necessarily people that have gone through traumatic events. So if you have somebody like a burn patient, you may have to consider using staples and alligator clips to actually be able to get the leads to stick, because if you've got tissue that's sloughing off, you may not be able to get a good viewpoint from that. So you really have to kind of evaluate what's going on with the patient. A little trick here. 12 lead EKGs don't actually have 12 electrodes. There's really only 10 electrodes there. As you start looking at some of your substituted views, say for instance, you're doing a right-sided 12 lead or a posterior 12 lead, you're just going to move your precordial leads around for those patients, and you'll make sure you document that. But there's only 10 electrodes on a 12 lead, one for each of the extremities, and then six on the precordial leads or the chest themselves. Other things to think about, limb leads need to go on the limbs. A lot of times we kind of shortcut things, we put them where they stick. But you really need to make sure that you have them down from that viewpoint. So we try and avoid putting leads on the shoulders. Make sure if you get them on the arms that they tend to go a little bit lower down on the arm. In a perfect world, they're actually supposed to go down on the wrist, or maybe on the forearm. But traditionally, we put them up on the shoulders because that was easier for us. Everything reached a little bit easier. But it doesn't provide you the exact same viewpoint you're looking for. And then same thing down on the legs. They're really supposed to go down to the ankles, but sometimes we kind of shortcut it and put it up on the thighs. And it may provide you an appropriate reading, but it's not necessarily the most accurate reading. Precordial leads, we're going to look at a picture in just a second, but make sure you know where the precordial leads go. On the exam as well as on boards, a lot of times they will ask you what intercostal space you'll put things. They really like to do V1 or V2, just because those are easy to note. So just know that those are going to go at the fourth intercostal space, starting on the right side of the sternum, then to the left. V5 tends to be kind of on the anterior axillary line, uh, and then V6 is down on the mid-axillary line. So kind of as you're working your way through V4, 5, and 6, they're all going to track around that fifth intercostal space, but you're going to start off at your mid-clavicular line with V4, V5 is going to be the anterior line, and then V6 is going to be over on the mid-axillary line. So it kind of wraps around the heart. If you think about it, it provides you different viewpoints of the heart as it's doing that. And this is just a picture kind of illustrating what I was talking about there. So ways you might see this deployed, you might get a picture and it says, which 12 lead viewpoint is this? All right, so now we're going to take a look at a traditional 12 lead. Sorry, the kids are playing Fortnite, and apparently that's really important for everybody to hear. So this is not the greatest 12 lead, but we're going to take a look at it and talk about some of the characteristics we see here. So starting off, things you'll commonly see on an EKG. A lot of times there's some patient information there. So age, sex. The computer does a very good job of analyzing what it's given, but sometimes patient factors come into play that can influence things. So if you skip through the age of the patient, it may miss out on some of the interpretation data. It may also kind of give you vague statements like correlate with age, correlate with clinical condition, because it may not have all the information it needs for that interpretation. So make sure you put in the age, sex. A lot of times that's also how it gets reported to the patient's EMR or billing. Um, Commonly now in large facilities, this is done for you, but you may see if you're working in a surgery center or maybe an office-based practice that you're the one that actually has to input some of the data or even do the test itself. So make sure you don't take shortcuts, especially since those tend to be a little bit older machines that may not have some of the newer technology. Other things that it tends to figure out for you, your axes, your P, your QRS. It'll figure out your PR interval. It'll figure out your QRS duration, and it also calculates your QT and QTC for you. Now, if you have a poorly performed 12 lead or an EKG like this that's got a lot of artifact in it, it may be difficult for that device to actually calculate everything. So as you see here, there's lots of kind of artifact, especially on your traditional 5 leads. So it may be hard for the machine to figure out something like a PR interval. So it provides you with lots of information, but it may not be accurate based off of what goes into the machine itself. So just take some of that with a grain of salt sometimes. All right, we're going to talk a little bit about how to label the different QRS waves. And this gets a little bit confusing as we kind of move through things, especially bundle branch blocks. I don't want you guys to get horribly bogged down in this because it'll make a little bit more sense when we look at those bundle branch blocks. But just know that you may see some transposition of the different waves depending on what you're looking at. So these are kind of the definitions to start off with by learning. So the first negative deflection after the P wave in any lead is going to be your Q wave. And we say that because sometimes you'll see situations with bundle branches where you're actually able to see the ventricles in their own separate kind of worlds, if you will, where they're actually two different impulses as opposed to one merged impulse. So it may be difficult sometimes to make out the Q wave when you have those overlapping ventricular efforts. So the R wave is the first positive deflection after the P wave in any lead. So Q wave was negative, R wave was positive. And then the S wave is the negative deflection after the R or the Q wave. And the reason we say that is because sometimes you will have a hard time differentiating like the R or the Q, so that may make things a little bit more challenging for you as you work through things. So if you're looking at these complexes here, you can make out in that first one you have a traditional QRS. The one in the middle, you don't really have a R because it's a negative deflection. So it's like a QS. And then that third complex over, you have a Q, then an S, and then your R to follow that. So it can be kind of a confusing setup for you depending on what's going on. So the important thing for you to think about, and this is why I say don't get too wrapped up in the other, is figuring out your J point. Because your J point is where your QRS ends and you transition into the ST segment. And this is really the important point for you as you start trying to figure out whether it's a left bundle branch or a right bundle branch. And we'll talk about an easy way I use to kind of study those or evaluate those in just a minute. Sorry, my computer froze up. There we go. All right, so let's take a look at these morphologies. So we have an upright R wave to start off with. Then we have negative deflection for a QS. On the far right side, we have a QRS. On the bottom left, you have an upright R followed by a negative S. The next complex is a little tricky because you have a Q and R and no S. And then the third one is really what we start to see when we start, or not the third one, the third one on the bottom is what we really start to see when we talk about bundle branches because you have what we call RSR or RSR prime. So here you're actually able to make out the efforts of two different ventricles. Now the drawing here doesn't really do it the justice that you'll see in just a minute when we actually start looking at a 12 lead with the bundle branch block. So next thing we're going to talk about just for a little bit is how to figure out the axis deviation for patients. People tend to get really bogged down in this. Please don't. I'm going to show you a chart in a couple minutes. That's all you really need to remember about axis determination because it kind of helps you figure out the axis very easily, but it also helps you think about why it's important for patients. So big things we use when we start talking about a hemi block or a bifascicular block. Those are the patients that we have to be very concerned about giving lidocaine to because they've got a pretty significant impairment through their ventricular conduction system. We can also use that axis determination to try and figure out if this is a patient with potentially atrial fibrillation with some sort of aberrant conduction, or if this is actually a ventricular tachycardia. So axis can be really complicated for folks, but all you really have to do is think about axis is how the electricity is flowing through the heart. And we look at the QRS complexes to figure out the ventricular axis. So this is kind of an example of it. We've talked about this several times, but if you follow this impulse from this yellow dot over to the red dot, you're going to have an upright complex. On the other hand, if you look kind of at the bottom, we're moving away from the monitoring electrode. That's going to give you a negative deflection. So that's what you kind of have to think about, that coupled with leads 1, 2, and 3, because those are the different viewpoints as we're looking at it through the heart. So this is a normal axis through the heart. So we're starting off and we're just going through our ventricles here, but we're going from our AV node down to the base of the ventricles. So we're traveling towards all those monitoring electrodes. So if we have a normal axis, we will have upright QRS complexes in each of our leads, 1, 2, and 3. If I have a patient that has some sort of left axis deviation, I'm not going to continue all the way down through the ventricles. What's going to happen, I'm moving away from lead 2 and lead 3, but I am continuing towards lead 1. So I have an upright lead 1 and a negative lead 2 and lead 3. Right axis is kind of going to be the opposite. So I continue partially down through the ventricles, and then I deviate towards lead 3, but I'm moving away from lead 1 and lead 2 at that point. If I have a patient with extreme right axis deviation, excuse me, think about a rhythm that's originating down in the ventricles, I will have negative impulses in lead 1, lead 2, and lead 3. But if I happen to have the ability to monitor V1, I may notice that I have an upright wave there. And like I said, we'll get to that chart in just a minute and it'll make a little bit more sense for you. So things that are important for us to think about when we're looking at axis determination, we've got to make sure our leads are in the right place. And then we just have to figure out those 3 leads. So lead 1, lead 2, and lead 3. And that will make things really simple for us. So this is that chart I'm talking about. So in your minds, memorize this. This is just summarizing that information that we were just looking at. So in a traditional axis, you'll have positive complexes in all 3 leads because we're moving down through the normal conduction pathway in the ventricles. On the other hand, like we were talking about something that may be ventricular in origin, like ventricular tachycardia, I'll have negative leads because the rhythm is originating in the ventricle and tracking back up through the heart. So that impulse is moving away. So then in the middle, we kind of have to progress through things in a stepwise fashion. So for a physiologic left axis, which tends to not be clinically significant, I'll have a positive impulse in lead 1. Lead 2 may be positive or transitional, depending on exactly where it transitions through the ventricles. And then lead 3, because I'm deviating to the left, will be negative because I'm moving away from that lead 3. Pathological, which is where we really worry about it being a clinically significant left axis, because I may have blockade of that anterior hemiphysical, is that I'll have a positive lead 1 because I start down through the ventricles in a normal fashion, and then for lead 2 and lead 3, I'm transitioning off to the left. Right axis deviation, not extreme right axis, but right axis, negative in lead 1, and then lead 2 can be really either one of the 3, and then upright in lead 3. And then again, talking about the ventricular component for like a VTAC for extreme right axis deviation, they'll all be negative because it's starting in the base of the ventricles and moving on. Now that's confusing. Does the chart help it make sense? Okay. There's some yeses, some nos. We're going to look at some examples that'll kind of help you out with things. So as we start looking at this, if it still doesn't make sense to you, let me know. All right, so let's take a look at this top left EKG here. What do I see? So lead 1 is upright. We think it's upright or negative? It looks negative to me, right? So the R wave is pointing down. All right, so I'm already kind of narrowing things down. So I'm thinking right now it's probably going to be something that's originating a little bit lower down in the ventricles, right? So lead one is primarily down. Lead two is upright. Can we agree our R wave's pointing upright for that patient? Okay. So now I'm thinking it's probably a right axis deviation. And then when I look at lead three, which is also upright, it confirms that for me, right? So does that make sense to everybody? Just using those three leads, I can figure out that this is a right axis deviation. All right, let's move to the one down below that. So this is obviously a tachycardic rhythm. So what do we think's going on with lead one? That looks negative, right? Lead two looks negative, and lead three looks negative, right? Can we all agree on that? So this is something originating deep down in the ventricles like a ventricular tachycardia. Make sense? All right, let's look at the next one over. This one right here in the middle. So lead one, I think we can agree is upright. Lead two is upright, and lead three is upright. So this is a normal axis deviation. Make sense? And then moving to the top right over here, lead one is upright. Lead two is kind of indeterminate, right? It's really kind of 50-50 depending on which complex you look at. And then lead three is negative. So this is a physiologic left axis. I'm not really concerned about pathology here. And then this bottom right EKG, lead one is upright. Lead two and three are both negative. So this is a patient I'm concerned about some sort of hemiblock going on. Does that make sense as far as interpretation? So let's talk a little bit about what's going on in the ventricles itself at this point. So what you'll see is that if you have a ventricle that's hypertrophied, it will cause the axis to shift towards the area that's hypertrophied. Um, so the way I generally think about this is that it's pointing to the problem. So if I have somebody that has left axis deviation, I'm thinking that there's something going on in the left ventricle. So for instance, some sort of blockade of the anterior hemifical. Other things you'll see, aortic disease can cause it sometimes for the left side. Hypertension can cause hypertrophy of the left ventricle. Think about things that are affecting kind of that specific area. So hypertension is generally a systemic disease. So the left ventricle provides perfusion to that portion of the system. Same thing. The aorta is in the left ventricle. So if I'm concerned that there may be some sort of LVH, it's probably pointing to either hypertension or an aortic issue. On the other hand, on the right side, we're thinking about perfusion to the lungs. So if I have right ventricular hypertrophy, think about things like pulmonary artery hypertension, PE, some sort of pulmonary valve disease, or other severe lung diseases. Does that make sense as far as like trying to figure things out? Um, Physiological left axis, we generally don't worry about quite as much because it can be a normal finding for some folks. And it's kind of interesting because it's a normal finding in two extremes. You'll see that it's a normal finding in obese patients, but it's also a normal finding in patients that are very athletic. Mark asked about hemiblock. We're going to take a look at the conduction systems through the ventricles in just a minute and hopefully explain that really well because it's a little bit easier to understand that when we're actually looking at it. So if we look at that and it still doesn't make sense, just let me know because it is really confusing. And until I started learning about 12 leads, I had no clue all the potential damage I'd done to people by giving some medications. So it can be kind of a warning sign for you, and it makes giving little things like lidocaine a little bit scary. All right, so now we're going to move on to bundle branch blocks. So we have two main bundle branches in the heart, the left or the right. And what they do is essentially take the cardiac impulse as it comes out of the AV node and takes that impulse all the way down through the ventricles. And the reason it does that is it's causing those ventricles to contract together or in synctum. So when we run into problems with the blockade of one of those bundle branches, that's why we no longer have an effective contraction a lot of times in our patients because it's no longer functioning in synctum. So it each one's kind of doing its own thing, and they're close together, but as opposed to getting a very effective squeeze, we tend to get kind of an erratic impulse for our patients. So this is kind of the normal conduction system through a heart. So as you look at the AV node there, I'm going to turn on my cursor for us, hopefully. Starting off here in the AV node, we come down and we have two bundle branches. So we have the right bundle branch, which tends to be kind of straightforward by itself. And then you have the left bundle branch here. So the left bundle branch really has a couple different components to it. You have the anterior component that we see here, and then you have this posterior component that kind of influences the contraction of the posterior portion of the wall. And you'll notice that we really focus a lot on 12 leads in the left side of the heart because they don't look at the right side very well. But there are some things like right bundle branch block that you can actually get a little bit of information out of without doing a right-sided 12 lead. So I really wish I could see you guys in class right now because this is kind of a telling thing. How many people know which way when you put on your left turn signal it points? So if I take my hand and put it on my turn signal, and I'm going to put on my left turn signal, which way do I push? Up or down? It's down, right? So if I'm going to turn right, it goes up, right? So the reason I'm telling you this is going to help you go back and figure out those bundle branch blocks. And this, I have to dumb things down for me, but this is one of the easiest ways for me to remember it. So a left bundle branch will point down, a right bundle branch will point up. So what we're going to do is think about the criteria to be a bundle branch. So it needs to be wider than 0.12, and we're going to look at lead V1 or MCL1, whichever one you want to use. And MCL1 and V1 are essentially used interchangeable. So things that we have to worry about, and one of the reasons that bundle branches are kind of a big deal to us, we touched on it, but as you lose that symptom of the heart, it affects your contractility. When it does that, it's going to result in a decrease in your blood pressure. Maybe it's clinically significant, maybe it's not. But what you're going to see is that there's an increased likelihood of decreased perfusion, and there's also a pretty substantial increase in the mortality rate for patients if they have a bundle branch block in the setting of an acute MI. So it's usually about 4 times that, which makes sense. If you have somebody that's having an MI and it's clinically significant enough that it affects the conduction system through the ventricles. So unfortunately, we didn't get to laugh at the person that couldn't remember which way their turn signal went, and figure out that, they don't use their turn signal at all because they don't have it. But I'm telling you guys, somebody out there is one, not using their turn signal, and two, yeah, my BMW was perfectly normal, so I don't know what you guys are talking about. All right, so looking at this a little bit closer. So we're going to look at some strips here in just a second, but these are the things I need you to remember and how we're going to kind of work through it in a stepwise fashion. So first of all, we're looking at lead V1. We're making sure our QRS is greater than 0.12, and we're going to find the J point. Remember, the J point is where we kind of transitioned from being in the QRS into the ST segment. And then we're going to draw a line back into the first complex that we have and figure out which way it goes. So we're going to make a little triangle out of it. If the arrow points up, right turn signal, right bundle branch block. If the arrow points down, left turn signal, left bundle branch block. So these are those complexes I'm talking about here. So if you look here, this is our J point. So I'm going back into my QRS complex, and I'm following the first complex I get to. So I go back into this complex, and it's pointing upright. See how I made a little colored in arrow there? So I've got a right bundle branch block. On the other hand, if I have a negative deflection, I'm going back into the complex and going down, I have a left bundle branch block. Now, the ones that we'll really get confused on is when we have a pretty pronounced bundle branch block where you're able to actually kind of make out RSR, because you have to really focus on that first complex for that patient. So in our minds, we probably want to go to this bigger complex here, but what you really need to do is go back into this first complex coming out of the J point and go down. This one's a little bit easier because that complex over here isn't quite the distraction that this one is. But just go back into your complex and go down, complex and go up, complex and go up. Does that make sense to everybody? All right, cool. So now we're going to talk a little bit about why that matters. So we know how to identify it now, but let's talk about why it's clinically important to us. So this drawing's a little bit more crude than the nice picture of the heart earlier. But on the right side, you know that we have our right bundle branch block that comes down. So these little hash marks here are blockades. So when we looked, we had two components to that left ventricle. We had the posterior component and the anterior component. So what I'm talking about when I say a bifascicular block is a blockade of two portions of the bundle branch. So remember that the left bundle branch by itself has two portions, and then there's the right bundle branch. So in this patient I'm looking at right here, what I see is that I have a blockade of the right bundle branch, and I also have a blockade of the anterior portion of the left bundle branch. Does that make sense to everybody? So remember, your left has two portions, the right only has one portion. So you have the posterior and the anterior. So these are the patients that we really have to worry about giving somebody a ventricular antiarrhythmic because they're very high risk that if I give them that medication and it works the way I want it to, that will slow the conduction through an already affected ventricle. So this is a patient that has a blockade of the right bundle branch, and then they have a blockade of the posterior portion of the left ventricle. Make sense? So if you have somebody that has a bifascicular block, you can almost think about it like they have two-thirds of their ventricle that's not working appropriately. So whether it's somebody that has a blockade of the entire left bundle branch, or somebody that has a blockade of a portion of the right bundle branch and a portion of the left bundle branch. So this is somebody that just has a blockade of their entire left bundle branch. So the anterior and the posterior component have both been affected. So even though there's no blockade of the right bundle branch, they are already at high risk because they've got their entire left side that's been taken out. So bad stuff follows that, right? So what we see sometimes is that these patients are at high risk because of poor perfusion. They're at high risk because of underlying cardiovascular disease. And these are the folks that you really need to think, hey, there could be something bad going on here. Now, how common is this? Some people walk around with bifascicular blocks every day, and they're doing fine with it. But if you have a patient that's clinically symptomatic with a bifascicular block, be very concerned that they're at high risk for cardiac arrest. This is somebody I would go ahead and consider putting the defibrillation pads on before I take them back for whatever case they're having. Does that clear up the bifascicular portion? Okay. Kyle asked, so V6 analysis is not required for bundle branch blocks, just V1, correct? So if you use the technique I showed you, all you have to do is look at V1. And like I said, it's as simplified as possible, but you can look at that and use it just to make your bundle branch determination for that. And that's just figuring out right versus left. So from that standpoint, we understand bundle branch blocks. We understand what a bifascicular block is, where we've blocked both fascicules now. All right, cool. So now we're going to talk a little bit about the blood supply to the myocardium. This is one of those things that you may have had a decent amount of exposure to, but we're just going to kind of focus a little bit more on it for right now because this is going to be pretty important to you in the future. So it's important for us to know how to take the data from a 12 lead and apply it to a patient's heart. So there's a wide variety of cardiac structures that perfuse the heart. I'm just going to kind of go through them step by step and talk about the artery itself and then what portions of the heart it supplies. And then we'll get into ST elevation and interpreting 12 leads and stuff in just a second. So the RCA, or the right coronary artery, primarily provides blood supply to the inferior wall of the heart, and the posterior wall. Those are both on the left ventricle. The right ventricle is almost entirely supplied by the right coronary artery. When we start talking about 12 lead interpretation, remember I told you that 12 leads really only look at the left side of the heart. So, like talking about the inferior wall, talking about the posterior wall, that's both on the left ventricle. We don't, in a traditional 12 lead, look at the right side of the heart. So, sometimes we can kind of gather shared data. So, if you have somebody that has inferior wall changes, a lot of times we know that that likely involves the right side as well, just because it has a shared blood supply. Other things that we tend to see affected by the RCA, the SA and the AV node. So patients that have had damage to their RCA are at very high risk for conduction delays and bradyarrhythmias. So sometimes the way they present is in a bradycardic fashion. Very rarely will you have somebody that's had a RCA occlusion that's tachycardic. The other thing for you to remember is that the posterior fascicle of the left bundle branch is perfused by the RCA. The left anterior descending, you'll hear lots of people call it the widowmaker because it provides a large portion of the blood supply to the left ventricle. So if you have an LAD occlusion, a lot of times your systemic perfusion is affected. So high risk of death as a result of that. The anterior wall of the left ventricle, the septal wall of the left ventricle, the bundle of His, and the left bundle branch are all supplied by the LAD. The circumflex, lots of people forget about. A lot of times they focus on the RCA or the LAD and they forget there's a circumflex there. And part of that reason is that the circumflex provides perfusion for the posterior part of the heart. So remember I talked about we only look at the left side. We also really only look at the left side of the front of the heart. We don't look at the back side. So sometimes we can glean information from what we call reciprocal changes or mirroring changes. So you may be able to look at an EKG tracing that shows you the front of the heart and know that there are some rhythm changes that occur as a result of damage on the 180-degree opposite side of the heart. So the circumflex provides perfusion for the lateral wall of the left ventricle, part of the SA and AV nodes, and then the posterior wall of the left ventricle. We're going to talk for a second a little bit about what happens in an MI because we get very focused on it's like an on-off process. It's not an on-off process. They're very slow things that happen. And based off of what's happening and kind of the clinical symptoms of the patient, we may be able to figure out how occluded that vessel is. Not with certain specificity, but for a kind of high percentage of patients, we can figure out where they fall as far as occlusion based off of their clinical presentation. So what happens inside the vessel? The plaque ruptures, it sets off this clotting cascade, which is what it's supposed to do. So the clot starts to form, and this is really kind of the intervention time for patients. This is when they can do something that may help with it. So if they start to have a clot that's forming, maybe they can do something like take aspirin. Obviously, going to the hospital and getting some sort of intervention is beneficial. But aspirin and heparin really work at this point as the clot's starting to form. So if they can intervene and prevent that platelet plug from forming, they tend to have a little bit better outcomes. But that's why we tell a lot of these patients to take an aspirin at the first sign of symptoms because they may help reduce the spread of that clot. So what are we going to see clinically? So if you have somebody that presents with chest pain on exertion, there's a potential they have about a 70 to 85% occlusion of the affected vessel. If they stop doing whatever they were doing and they go to rest and they continue to have chest pain, higher likelihood that they've got obviously a more significant occlusion, so like 90% occlusion. And then if they take a break and they take nitroglycerin and they're continuing to have chest pain, higher risk of them having a higher degree of occlusion. Now, this is not 100% guaranteed, but you can follow kind of the logical progression here, and it tends to correlate clinically pretty well. So how do we intervene for these folks? Oxygen is almost always good, although I think it's interesting as we start thinking about oxygen and some of the effects on free radicals that, maybe someday in the future we'll figure out that oxygen is actually bad for them and go away from it. But for right now, we're pretty good about following the oxygens for these patients. Nitroglycerin is a twofold process. It focuses on cardiac relaxation as well as improving perfusion to the coronaries themselves, and then pain control. Um, One of the things that's kind of fallen out of favor for a lot of these patients is we used to give them morphine for pain control. Morphine itself is not bad, but what does morphine do to their blood pressure? Lots of times we have a histamine release, and that histamine release will cause vasodilation, and then as a result of that, we have hypotension. So it's okay to give them morphine if you can sustain their hemodynamics. But if you give them morphine and have any sort of cardiovascular depletion because of it, it's bad. So as a result of that, for a long time we used morphine to treat our cardiac patients. We've gone to stuff that's a little bit more cardiac stable, like fentanyl. Now, on the other hand, what would probably not be a good choice of pain medication? What do we use for pain in a lot of people that might be the wrong answer here? We don't use dialysis for a lot of people. Yeah, ketamine would be a horrible answer for these people because think about what's going on in giving somebody ketamine. You're going to increase their heart rate, and as a result of that increased heart rate, you're going to have increased myocardial demand. So I have an area of the heart that wasn't getting perfused well enough to start off with, and now I'm increasing the workload on the heart. So sometimes what you'll see in these patients, not related to the pain discussion, is that they have ST changes that are associated with increased myocardial demand. So they do okay if they're sitting there, but then I ask them to walk up a flight of stairs and they start to have ST changes. And then they stop and they go away. What does that sound like? Has anybody ever seen a stress test where you have them actually do an exercise stress test as opposed to a chemical stress test? That's all that's going on there is you're putting a demand on the heart and seeing what sort of areas the patient may experience ischemia. So things to think about there. How do we treat these patients? So if I have somebody and I'm thinking that they're having some sort of MI event, two different ways I can treat them. Ideally, I can get them someplace where they can undergo corneal cardiac angioplasty or intervention. But maybe I'm in a smaller facility. Maybe I don't have that capability. This may be a patient I need to consider getting thrombolytics to. So our goal for those patients is to get them reperfused as fast as possible. Depending on what standard you follow, a lot of places are aiming for 60 minutes right now. That's great if you live someplace that has a cardiac center, but how many small facilities have a cath lab? Very few of them, right? So what we're seeing for a lot of those patients is that they're getting thrombolytics and then they're being transferred someplace else for definitive care. So that way they can start reperfusing. Now, thrombolytics are not as good as directed cardiac intervention, but they're still beneficial for those patients. So, what sort of things are contraindications for thrombolytics? So, Rochelle asked, would it delay them going to the cath lab within a time frame? No, you can give somebody full strength thrombolytics and then take them to the cath lab. You just know that you have kind of some increased risk of localized complications like bleeding, obviously. Growing hematoma is a big one, but you can still take them directly to the cath lab. Yeah, so any sort of hemorrhage is really the big thing we worry about for these patients. So if you have somebody that's been in a traumatic event, probably don't want to give them something that can make them bleed out of everything. One of the big ones we worry about is patients that have had a stroke or are actively having a stroke, especially if it's a hemorrhagic stroke, because they're actively bleeding at that point, and there's no way we can hold pressure in your head. If you have somebody that had an untreated embolic stroke, it may have resulted in weakness in the cerebral vessels, so that's a risk for us as well. Uncontrolled hypertension is another big one. Now, the good news is usually we have enough medications that we can get patients' blood pressure under control. What about somebody in PACU that's having an ST elevation MI? If they're in PACU, they probably just had surgery on something, right? So they may not be a candidate for thrombolytics because they just had recent surgery. Other things we worry about, patients that may have bulging vessels. So somebody with like an AVM, somebody with an aortic dissection, those patients are folks you probably don't want to give anything that's going to make them bleed because they're at increased risk. So those are the big things we really have to worry about. Patients that are high risk for hemorrhage. So if you think about those things, it kind of makes sense. Or those folks with uncontrolled hypertension. There are some other kind of things you have to consider, which fortunately aren't quite as common. If you have women that are pregnant, there's some concern about giving them thrombolytics, that it's very high risk to the fetus. On the other hand, if mom has an acute MI and dies, it's probably not great for the fetus either. So a lot of times what you have to do after you move past the absolutes is kind of have a risk benefit or risk balance discussion for these patients. I can do this and it may save mom, or I can do this. Maybe you had somebody had lower extremity surgery. I can give them the thrombolytics and save their body, but I may have bleeding issues from this extremity. So things like that. Other stuff you'll see done not so much in the setting of cardiac events, but in stuff like PE. We may do catheter-directed therapy where we'll give very small doses of thrombolytics right at the site of the clot. So maybe there was a clot they tried to intervene with and it didn't work. And then as opposed to giving systemic therapy, they may give localized thrombolytics to that patient, usually during a continuous catheter infusion. So that's something you want to be thinking about in the back of your mind if you do have somebody that's at risk or seems to be experiencing a ST elevation MI. So other things for us to think about for these patients, I've said it multiple times, but EKGs only catch about 50% of MIs. So those are the ones we hear referred to as ST elevation MIs. So about half the patients that have an MI, we have no EKG documentation of it. Maybe it's because we didn't look. So maybe this is somebody that had like a posterior wall MI or right-sided MI, and our traditional 12 lead didn't catch it. Or maybe it's because it was something that just didn't show any electrical abnormalities. So for those patients, a lot of times what we do is trend them with cardiac enzymes. And then sometimes we ultimately have to just look at the patient. If you have somebody that's continuing to have chest pain, in spite of having no EKG changes, they may go ahead and cath them. And sometimes they'll go ahead and do a CABG when they get in there based off of just narrowing of those vessels. So maybe it's not to the point of a high degree of occlusion, it's not past about 70%, but maybe that little bit of demand ischemia caused by the reduction in flow is enough that they're having continuous pain. So they may go ahead and intervene. The other thing is that there are a lot of conditions that look like MIs that are not, and some of them can be devastating. We'll talk about those in just a couple minutes here. So this is a big thing you've got to keep in your mind. A normal 12 lead is not reassuring. If you have a normal 12 lead on a patient and they're continuing to have symptoms, think that they may still be having a problem. And it may not be the problem you're trying to find. So 12 leads aren't all garbage. The good news is if you see somebody that has ST changes on a 12 lead, they're pretty specific. If it shows an MI, there's probably an MI. It usually detects them very early on, and it also tells you where they're having kind of impact, which part of the heart's being affected by it. So when we start thinking about what's going on in the heart itself, we need to kind of think about the timeline here. So our goal is to try and intervene as early on as possible for these patients because as things progress further and further down the line, what we see is that they transition from kind of an ischemic period where it's not getting enough blood flow to an injury period where the heart itself has been damaged. And what we're ultimately trying to prevent is them getting to this necrotic period. So if you have a patient that's had an MI, at about the 2 hour mark, there's about a 50% potential that that tissue has had necrotic injury. And as it goes on, it obviously becomes worse. And the reason I say that is we need to think about what's going on in the heart during those time periods. So we started off with ischemia. Ischemia, we're having some sort of transient reduction in blood flow. So maybe it's demand ischemia, maybe there's occlusion. And what we see initially in those patients is that you tend to have inverted T waves. And remember, as we're talking about all these things, that I want to have two or more related leads that are affected because sometimes we'll just get a one-off in a vessel. So don't get fixated if you just have one lead of ischemia or one lead of injury. It's when we start talking about multiple leads and multiple associated parts of the heart. Something else that you have to remember is a lot of times in lead 3 and lead V1, you will have normal inverted T waves. So that may not be a factor for you in those patients. So let's stop and look at a normal 12 lead. So when we look at this, I said that lead 3 and lead V1, it's normal to have inverted T waves. Doesn't mean it always happens, but it can happen. So I don't see it here in lead 3, but when I come over and look at V1, I have inverted T waves. But it's not normal to have inverted T waves in V2, V3, V4, and V5. Does that make sense? So something as subtle as an inverted T wave may be significant. It may be a sign there's something going on already without them having ST depression or ST elevation or any of those sorts of things. Now, there's obviously some other stuff that's going on with this patient. Like if I look at V1, it looks like maybe there's a little bit of ST elevation. If I look at lead 3 and AVF, I definitely see that there's some ST elevation there. So not a great 12 lead already for this patient, but something very pronounced like that T-wave inversion may be a little bit easier to distinguish than just a little bit of ST elevation. So I go from ischemia to injury. Injury is really kind of the point where I have to intervene. The downside is most of us did not recognize our patients were having ST injury until they got to this injury point, or ST damage, excuse me, because this is when we're looking for that ST elevation. So by definition, it's more than 1 millimeter and two or more related leads. So this is when we really started thinking about our patients having an MI in the past, because most of us didn't detect that ischemic time. So injury, ST elevation. So when you look here, it's pretty easy to make out that we're starting to have ST elevation. Now, one thing for us to figure out is we have to know where our isoelectric line is because that's really what we're elevating above. So when I stop and look here, here's my isoelectric line. I can kind of generalize that from the complexes I'm looking at. And I can easily see that I've got a little bit of ST elevation in lead 2, far more pronounced in 2 or in 3, and then again evident in AVF. So I have ST elevation there. What do I have going on with my other leads? So if I look at lead 1 here, what do I see? My isoelectric line is here. What's going on with my ST segment? It's depressed, right? So I have a little bit of ST depression. What does that potentially tell me? This may be that mirroring of the other part of the heart. So we'll talk about it again in just a second. But lead 1 and AVL are what coronary artery? Anybody know? So I'll take you through it my way in just a second. Um, but what I usually do is use kind of a system that helps me work through it by association. Generally, leads beside each other are contiguous, but like 1 and 2 are not contiguous. 1 and AVL are actually sharing a view. 2, 3, and AVF are sharing a view. 1 and 2 share a view. 3 and 4 share a view. 5 and 6 share a view. So if you look, I'm seeing ST depression here, I'm seeing ST depression here, and then in a lot of my septal and anterior leads, I have ST depression. So that may be that reciprocal change I was talking about that kind of shows us what's going on the other side of the heart. So let's look at this one here. When I look, here's my isoelectric line. So I've got ST elevation here. I've got ST elevation here. I've got ST elevation here. I've got a little bit of ST elevation here. Some people will refer to this as like a fireman's hat if you think about the old school fireman's helmets that had this big front on it. So when I look at this patient, I'm seeing ST elevation in my septal and anterior leads. One of the big takeaways there was don't let age distract you. This was a 31-year-old. All right, and then to the final EKG change, we see ST depression. So ST depression may be that reciprocal change that I was just talking about that's reflecting on the other side of the heart. Um, if you don't have ST elevation anywhere, then start thinking that it's probably going to be ischemia or like a subendocardial injury. So I don't see ST elevation anywhere else. So like on that first 12 lead we looked at here, I could see I have inferior wall changes here. So I have ST elevation here. On the other side of the heart, I have reciprocal changes. I have ST depression. Does the relationship there make sense to everybody as far as having kind of a reflection there? Okay. So you may have reciprocal changes. You can also have subendocardial injury, ischemia. And then sometimes you'll see that some of our medications or electrolyte abnormalities can do this as well. So like digitalis does all sorts of crazy things to the heart. So you may see that reflected in ST depression. You may also see it in hypokalemia. So these are some examples of pretty impressive ST depression, especially when we start looking at like AVL here. So one in AVL, pretty significant ST depression, and then V1, V2, V3, V4. So they have high lateral changes as well as septal, as well as anterior. So pretty significant MI here. And then when I look, I've got ST elevation in 2, 3, and AVF. So what I'm actually seeing is that the patient's having an inferior wall MI, and these are all reciprocal changes. Does that make sense to everybody? All right. And then moving on to the third component, when you actually have infarction, an infarction is essentially necrosis of the tissue. So what you see in those patients is that they will have what we call pathologic Q waves. And pathologic Q waves are Q waves that are either a third of the depth of the R wave in height or they're greater than 40 milliseconds wide. So, things to think about with these patients. How acute are they? So you may have a hard time figuring out if these are acute pathologic changes or if this is a chronic condition. If you have a patient that has acute MI from other findings, then consider this to be an acute finding. If there are no ST elevation or ST changes, then consider this may be a chronic condition. So this is what it looks like here, and it kind of stands out when you look at the EKG. Notice how you just have this huge pronounced Q wave over here. So that looks kind of strange to us. So what you have to do is take the Q wave and measure the height of it, and then measure your R wave and figure out if it's more than a third of the depth or height. And in this case, it's almost like a half of it, so that's pretty straightforward. That's a pathologic Q wave. So this is the system I use, and I'm going to show you a 12 lead here so you can kind of understand it a little bit better as well. But some people will say I see all leads. There's all sorts like mnemonics to help you figure it out. But what I do is I start off looking at a 12 lead, and I look at the shoe or the boot first. So looking at this 12 lead, the first thing I'm going to do is look at the eye, so the inferior wall. So shoes go on your feet, inferior is on the bottom of the heart. So I'm going to draw a shoe here around the inferior wall of the heart. See how it's like a little shoe there? So that tells me that lead 2, lead 3, and lead AVF are all looking at the same portion of the heart. So if I see changes in 2 and 3, 3 and AVF, that signifies to me that I've got damage to the inferior wall of the heart, which is supplied by the RCA. Now, the other thing I have to think about is where would I see reciprocal changes for those patients? And so I'm looking at the bottom of the heart. What gives me the best view of the top part of the heart? The high lateral. So 1 in AVL is where I would anticipate seeing reciprocal changes. So that's where I start off. The next place I go after that is 1 in AVL because I'm looking for my reciprocal changes from the inferior wall anyways. But this is the high lateral. So even though they're not beside each other on the EKG, they're contiguous because those are showing me the blood supply from the circumflex to the high lateral portion of the ventricle. Then I come over here and start looking at my precordial or my chest leads. So V1 and V2 are looking at the septum. So LEDs are blood supply there. So V1 and V2, V3 and V4 are looking at the anterior portion, and then V5 and V6 are looking at the lateral portion. The blood supply to that lateral portion is also coming from the circumflex. So RCA, LAD, circumflex, circumflex. Make sense? So commonly what you'll see is that you'll have patients with injury to more than one part. So what if I have a patient that has ST elevation in V3 and V4, V2 and V3. So even though V2 is the septum and V3 is the anterior wall, they're right beside each other. So they're contiguous in that respect. Does that make sense? even though they're not necessarily looking at the exact same portion of the heart, this being septal, this being anterior. They're still contiguous as you travel through the heart. So I don't care if you use the boot, I don't care if you use the ICL leads. Whatever system works for you to remember which part of the heart is affected will get you very far in life, because you'll see this on the exam, you'll see this on patients, and you'll definitely see it on boards. So other things for us to think about as far as different types of MIs. Um, Inferior wall MIs are the most commonly seen, but fortunately, they're not fatal or as highly fatal as something like a LAD occlusion. So what you'll see in these patients is if you've got an inferior wall in the eye, even though we're just looking at the left inferior wall, about 30% of the time the right ventricle is going to be involved. We're just not looking at it. So if you have somebody that has an inferior wall MI, you really need to do right-sided precordial leads. And all you're going to do for right-sided precordial leads is take that V456 that you have wrapped around that fifth intercostal space and transition them over to the right side in the same location. And that'll give you a perspective of the right side of the heart. Other things that are common in these patients is that they tend to have bradycardia and hypotension, but that makes sense because we know the RCA provides blood supply to the SA and AV nodes. Because of referred pain, it's pretty common for them to have nausea and vomiting. So you may want to consider giving them antiemetics as well. Be cautious with these patients and giving nitrates. In the past, we used to say don't give them nitroglycerin at all. But the thought there is that an RV infarct affects their preload. So what you have to worry about is that if you give them nitroglycerin, they may have a pretty profound drop in their blood pressure. And it's kind of a two-part problem. So I need to give them nitrates to improve their coronary blood flow, but at the same time, I just have to make sure I'm supporting them. So what you may consider, how many micrograms of nitroglycerin are in a sublingual tablet or sublingual spray? Anybody know? Yeah. So it's zero point 0.4 milligrams or 400 micrograms. What's our normal concentration for a nitroglycerin infusion? We know? Oh, we haven't been in the ICU in a while. It's hard to remember. So our usual concentration for those is going to be, in most facilities, 100 micrograms per ml. So if I need to give somebody nitroglycerin, which is a more controlled way of doing it? Giving them 400 micrograms that I can't take back, or slowly infusing them with something that's as little as 100 micrograms per ml? And I could further dilute that if need be. The IV infusion is obviously a little bit more beneficial for them. So what we may consider in those patients, and it may take a little more work for you because you can't just reach into the Pyxis and give them a sublingual spray, is to give them a slow infusion of nitroglycerin. So you're getting that coronary vasodilation, but you're not getting that drop in blood pressure. The other thing you have to think about for these patients is that you may need to give them a coexisting fluid bolus. The problem with that is a lot of times in these patients, they have pulmonary involvement. So just something for you to think about there. Anterior wall MI. So highest risk of complications for folks. Big issues we run into, think about all the things that LAD supplied. So this is when we tend to see a lot of those perfusion defects to our bundles. So patients are high risk for ventricular arrhythmias. You may also see that they're high risk for complete heart block because a lot of times these anterior wall MIs will have associated RCA involvement as well. So big things to worry about in these patients, bundle branch blocks. If you do see that they have bundle branch blocks or hemi blocks, get those pads on quickly. As I mentioned, you may see that it carries over to the septum or the lateral wall. For these patients, it's okay usually to go ahead and give them nitrates, but the problem we run into is that a lot of times We avoid giving them fluid because they're very easy to fluid overload. So just be cautious with those patients. Issues we run into as far as looking at 12 leads and figuring out what's going on. Sometimes patients with left bundle branches may make it very difficult to figure out ST elevation. If you have somebody that has a left bundle branch, you may have to consider that that 12 lead is not of diagnostic quality just because you have issues. Other problems you run into, patients that have LVH generally have really big QRS complexes in their ventricular leads or in their chest leads. So you may not be able to see any sort of reciprocal changes because of that. So that can just be a problem for you as far as helping to figure out the reciprocal changes for a patient. Pericarditis, if you look at a 12 lead EKG and somebody has ST elevation in all their leads, start thinking it's probably not a global MI, it's probably pericarditis. Other things that kind of help you differentiate it, usually they present with kind of viral findings, so like flu-like symptoms, chest pains, things like that. They're not going to have any sort of reciprocal changes in their because they've got ST elevation everywhere. And a lot of times positioning helps for these patients. So as far as pericarditis goes, thinks about kind of differential diagnosis, things you can use to isolate it from something that's a little bit more considerable, like a global MI. And then another one we really have to worry about is patients with thoracic aneurysms. You can imagine if you had somebody that had a huge thoracic aneurysm and you started giving them nitrates and heparin, worse than that, thrombolytics, that there could be issues. So why do we see ST changes a lot of times in these patients? Um, a lot of times what you'll see is that there are ischemic perfusion defects at the root because the coronary supply comes off at the thoracic aorta. So you may see that they don't get any sort of coronary perfusion. So you could have kind of a twofer there that they've got dissection of the aorta and they've also got an MI, or it could just be a dissection of the aorta. So things to think about there to help you differentiate it. A big one is looking at their chest x-ray, seeing if they have a wide mediastinum. Um, and then patient history may be helpful as well. All right, so went through a lot of stuff there. What questions do you guys have from all that?
Can you go back through which coronary artery for which lead?
Yeah.
You zoomed on that.
Sorry. This is what you're looking for? So inferior wall, the coronary arteries down here below in parentheses. So the boot, 2, 3, and F, RCA, septum, V1 and V2, LAD, anterior LAD, 3 and 4, lateral, 1 in AVL, tends to be the circumflex, and then the V in the posterior is RCA, if you start doing like posterior right-sided leads. Paul asked if there would be EKG picture questions, and the answer is lots of them. So you will have 12 leads, you will have just rhythm strips, and it may be a scenario like you have a patient that presents with chest pain and these vital signs and this EKG, what's your diagnosis? Or, like ACLS type stuff. Same kind of thing. Sarah asked about the boot, so I'm gonna hop over and look at a 12 lead real quick and just kind of walk you guys through it. So what I was saying as far as the system I use to do EKG interpretation, I start off looking at the boot. So if I were to draw a shoe here, I go around 2, I go around 3, kind of the bottom part of the boot here, and then I go around AVF, and that's my shoe. And shoes go on my feet, and my feet are at the bottom of my body. So inferior wall is where my boot is. That makes sense. Next thing I do is go up to 1 and AVL, and that's the high lateral portion. And the reason I do that is if I have ST elevation here on the bottom, high lateral is the best perspective I get for the top of my heart. So if I were to see reciprocal changes, that's where I would anticipate seeing them is on that high lateral portion. And then I come over and I look at the septum. So V1 and V2 coming off that LAD. Look for changes there. Then I go on over to 3 and 4 for the anterior wall, and then finish with V5 and V6 for the circumflex. So RCA on the boot, circumflex is high lateral and lateral. So high lateral, lateral, and then LAD for V1, 2, 3, 4. Rochelle asked about how much weight should we put on reciprocal changes? Do they always happen or is it a severity thing? I don't know what the actual incidence is. But if I had somebody with ST changes and I saw ST depression, it's kind of like a confirmation, really, because I know that they've got reciprocal changes that's confirming for me that that's probably ST elevation I'm seeing. Sometimes what will happen is that you have ST elevation and it's somewhat questionable. But if I have reciprocal changes at the same time as ST elevation, that's like confirmation for me. What other questions do you guys have? Yeah, we'll talk about Sim here in just a minute.
I know there's like more likely leads that reciprocal changes are seen in, but can they be seen in any lead?
So usually if you think about kind of the mirror part of the heart, that's where you would anticipate seeing them. So it's usually like 180 degrees opposite of the damaged area. So if I had somebody that was having like an anterior septal wall MI, where would I anticipate seeing the reciprocal changes?
Posterior?
Yeah, posterior. So I may do a posterior 12 lead to see there's reciprocal changes. Do I have to? Maybe not, but maybe if I'm in doubt about it, I would go through and do it.
Okay, thank you.
Folks asked about practice resources. I'm going to put up some practice EKGs for you guys if you want to go through and work on your own. I'm not going to grade them. I'm not going to go through them with you, but there will be some resources. You can also look on YouTube and come up with a wide variety of systems. Some people have other EKG systems that work out really well for them. There's also some textbooks out there if you really want to read something. You can find it that way. And then I'm going to put up a couple, yeah, websites. One Tyler just posted is one of my favorites, and it's not just for EKGs. The problem for a lot of this stuff is it's very hard for you to get stuff published fast enough for some of the changes that are happening as far as like current management and stuff. So Life in the Fast Lane is a good one. MCRIT is another good one. I'm gonna put it in there for you guys. Some of these have like blogs, some of them have podcast, but there's a lot of just kind of base information there if you're trying to figure out like a general medical condition. And because they're able to update things so fast, you may get like the latest cutting edge information there. The caveat to that is that what you see here may not change in tests and textbooks for quite some time. And it's also a lot of stuff that's kind of a review based off of the latest research. So, something gets published off of a study right here, and then somebody turns around 2 weeks later and you get a competing study. So you may see that that's kind of confusing to you as well. So lots of things going on there, lots of kind of helpful stuff. This is another one that's kind of good for you. But those are the big ones that I use a lot of times if I have questions. All right. Renata asked about sim. So I'm assuming we're probably going back to like normal stuff tomorrow. If that doesn't happen, then this will obviously change. But at this point, if you were supposed to go to sim on Tuesday, plan on going on Thursday. If you were planning on going on Thursday, planning on going to the next session, I think it's next Tuesday. And we're going to shift that down the line. And then we will ultimately wind up adding on or changing a session on the back end of this sim. Does that make sense to everybody? So I'm not going to put out another schedule until I'm sure we're going back on Thursday, because otherwise I'll just wind up changing it and everybody will wind up with three different versions of stuff and more confused. But that's what I'm anticipating will happen. Does that make sense?